So I have to get some things straight first. When I enlisted in the reserves, I was originally an x-ray technician, so I did my training down at Brooks. So like most people in medicine in the Army are either brookies or reedies at some point. So like I have to point out that even though I started at Brook, I became a reedie, and that Deep is actually a reedie too. He's just stationed down there. So just if any of you that are in the military are either brookies or reedies, I want to straighten that out. So what I wanted to talk to you about today is a little bit of a history lesson of the current wars and what I think it may have taught us about pain management. I'll do the usual disclosures. You can see I have no financial conflicts of interest, and though I've held some leadership positions in the military, I've now stepped down from all of them. But I'm not officially representing the United States government or the Army or the Department of Defense, and these are my opinions rather than those of the military. So when we talk about this, I think one of the first things to talk about is why you might care as civilians. And I think many of you know that the patients we're privileged to serve, both the active duty service members and the veterans, actually get care from all of us. I expect that those of you who weren't in the military have seen patients that either are or were in the military, and I think it's important for us to have an ongoing discourse and an ongoing exchange of information to do the best job of taking care of patients who in reality float between our systems that could be taken care of by any of us at any particular time. I think one of the things that's worth noting as the military medical system changes, DHA at some time and in some fashion, this is sort of an ongoing both policy and political thing that if you follow the news, you probably know that DHA will eventually take over the major medical hospitals while the services will retain responsibility for readiness. So a lot of the business of healthcare stuff will be done by DHA, and how that happens is still evolving, but it will probably involve more civilians working in those hospitals. So people may care for that reason. There may be, opportunities for employment or working together with those. One of the ways that readiness will be achieved, and I won't talk much about the acute pain sides because we were able to get an expert with Deep to come and talk to you about that. But trying to build partnerships with civilian places that have access to a lot of trauma that, frankly, except for Brook, many of our hospitals don't see those patients in that setting and provide those experiences. So there's a lot of opportunities for us to collaborate, and those may grow in the not too distant future. The other thing that I think it may be useful for is when we see civilian disasters, example, out in California recently, there weren't many injuries from that, but if you remember back from when we were a little bit younger and freeways collapse, a lot of those things will look a lot like a war zone, and I think the things that we learn from those events on the civilian side and from wartime practice on our side are useful to each other, and that we'll be able to do a better job of taking care of patients in both of those settings if we learn how to do good medicine in bad places, bad situations. So we talked about mixed metaphors. This is a mixed timeline. So this is, if you look at the first part, it's really part of military history, that this first period from 9/11 up to the military surge. I switched over to a CDC period at that point. The CDC talks about the opioid epidemic that we're all well aware of being in a couple of waves. A wave that went from 2007 that basically correlates with the surge time period to 2010, when prescription opioids were focused on and were realized as being the biggest problem in complications of pain treatment with opioids. And then finally looking at the third period, the more modern one, starting in 2013 to the present, where there was the rise of illegal opioids, synthetic opioids from other countries, creating the majority of our morbidity and mortality in that realm. So the first period was marked by some unique things in military history, some unique things kind of in pain management history, as we'll talk about. There was unprecedented survival of combat wounds. There was a lot going on there in terms of body armor, frankly, in terms of how well that our warfighters fight wars. And we see the rise of regional anesthesia, a lot of focus on acute perioperative pain medicine and acute post-injury pain medicine, trauma care. There was a lot of focus on overcoming pain management challenges en route care when people are being transported basically either in planes or in sometimes ICUs in the air for really unprecedented distances of 5,000 miles was not uncommon. And in addition, even during that period, there was some early literature suggesting there might be a role for chronic pain. And to a large extent, most of what I've done in the military is chronic pain, so I'll focus a little bit on that as well, although that became more of a focus in the second and third period. So go a little bit quicker here. So obviously this kicked out on 9/11, and so while some of these things existed, and many of you are like, well, that already existed. We had peripheral nerve catheters. My point is, on the battlefield, much of this wasn't used when this happened. So that there was really no use of continuous peripheral nerve blocks when somebody was injured in an operational setting, which at that time there wasn't a war, but there's always a low level of those kind of kinetic events going on, and these things weren't routinely used. Then frankly, there was minimal regional anesthesia. Traumatic amputations were a really small wartime problem for a long period of time. You really had to go back to Vietnam to see large amounts of that type of an injury. So IED reality made it so we could focus on these things in a bad way, in the sense that particularly IEDs early on were small devices that tended to create extremity injuries in the setting of body armor that limited more truncal injuries, and then obviously head injuries are another part of that we won't talk as much about. So why were all these things not going on? The mainstay of pain management on the battlefield, dating back to the Civil War, was morphine. And various times through the history of military medicine and military injuries, there were a number of things tried, but to a large extent, there was some argument being made that morphine was tried and true. So there was wariness about what kind of complications there might be with various other modalities on the battlefield. So I think we have to give some credit to Jack Childs, who Dr. Silverman knows well, was a leader, a mentor for me, for looking out not only in this area for pain management. He set a couple of people, Scott Kroll and eventually Trip Buckenmeyer, to train in acute pain and regional anesthesia, such as deep trained in eventually, that gave us some capabilities there we wouldn't have had. He also did a lot of things with TIVA for head injuries as well. So those folks kind of set the stage for getting away from that wariness to try something new. And the other thing is morphine caused a lot of problems. When we started having casualties, we realized that even though morphine can do some good things, and certainly this seems like an understatement in the current era, but early on in the war, there wasn't necessarily the focus on opioids there is now, and people were like, we already have a solution for this, why are we really spending a lot of time on it? And those people weren't necessarily bad people, they just weren't the visionaries that some of the other folks turned out to be. So we talked about this a little bit, so I'm going to go through it pretty quickly. So one of the things I'm going to point out that we'll talk a little bit later about is the low numbers of casualties. That's one reason that we were able to do these things. Like if you are a fan of military history and you look back, if you look at one day of battle at Antietam, in the 20,000s, it took us years to have that. I mean, we probably still haven't had as many deaths. So like the amount we owe to good war fighting and good medicine is significant, in the sense that the number of people that were injured, especially for Americans, was small, and it gave us the opportunity to do care that in many instances mimicked what they could get back in the States. And we'll talk about what that may mean for the future and how it involves civilians a little bit later in the talk. I'm going to go on past that stuff. Some technology broke out there with ultrasound, nerve stimulators, that let us do blocks perhaps better than we could have. There's probably people, anybody in the room done, other than me, that's done regional anesthetic blocks by landmarks? Yeah, and I figured when I looked out, the majority of you did this. So like, when I grew up, we had nerve stimulators. I was like, that's archaic. We have these nerve stimulators, and I'm sure Deep probably says, why would you do that with a nerve stimulator instead of an ultrasound? But that technology sort of made an impact quickly when you had amputees, because it's not ideal for landmarks, it's not ideal for simulators either, so it gave a window to be able to work on those things. This is just a picture that I stole from Trip Buckenmeyer at some point, so credit to him, of the inside of a aircraft that would bring patients back. So you can understand the kind of challenge that exists in that environment, and that created some of the impetus for the things that we see that changed during that period. And in terms of it being a loud, noisy environment, the need for patients to be able to have patient-controlled analgesia, not only because there may not be enough people to take care of them as quickly as you like, but also because of the safety benefits. And what did regional anesthesia growing up, so peripheral nerve catheters, mean back in the States? This is one reason this is important. These were popular when they got back. The catheters, we figured out pretty quickly, could be maintained for a long period of time with a low infection rate. Patients that came back with injuries that were unprecedented in terms of survival, because you had really bad extremity injuries with people that had their trunk protected and were able to be treated and rehabbed over a period of time, but that meant a lot of surgeries, and those peripheral catheters are very helpful in that setting. What we found out during that period, that this is not a doctor thing, it's a team thing, having well-trained acute pain nurses to be able to get to those patients out on the ward while surgeries are going on and anesthesiologists are in the OR ended up being very important in allowing those patients to get the best care. So trying to do this on your own or without leadership buy-in, and that'll be a recurring theme here as we go through this. If you can't get the leadership of your health system, of your hospital, of your facility to buy into doing those things, it's going to be a really uphill climb. Likewise, if you are a leader and you support this sort of thing, or you're able to convince your leaders to support it, it can make it much easier, even when it's something that's going to encounter some resistance, as many new things do in that setting. So I'll talk a little bit quickly again, still in this first period, about chronic pain management. This is me in, this is an interesting story. I'd gotten down to the mess hall. It was like a half a mile away. You can probably see I'm not quite as chubby as I am now in that picture, but I still wasn't really the runner. So I remember they had a difficult airway, and I'd run back from the DFAC to help manage the airway and put the airway in the picture at the top. But in addition to doing those things that are cool or out of a movie you might have seen on on TV during that time period, there's a lot of downtime. And during the downtime, that's an example. We're over in the graveyard for the T-72s from the GWAT war, before the GWAT war, back to the early 90s, and just a picture of probably smoking cigars or drinking fake beer with the team after we got there. But in addition to that, there was also some opportunities to do interventional pain in theater, and we would do those things when we had time and people needed it. And for a force that's increasingly older, increasingly has more specialization, it is important and potentially will become more important to keep those people in theater doing their job. We did some literature that kind of supports that. In this picture, we're doing a pretty straightforward transfemoral epidural steroid. The people you kind of see in the back are actually the bed control, so they're moving that stretcher up and down so we can do the ESI. So these are some of the reasons you might want to do chronic pain far forward. When we looked at people being evacuated, they get evacuated, and they're not likely to come back to the war. So there is some argument that something like chronic back pain might better be treated like we treat people with acute stress reactions, those sort of things where you take care of them in theater. Nowadays, a light concussion, you might have downtime in theater, but keep those people there. There's a couple reasons for that. One is just the way the system's built. It's meant to evacuate people. It's not particularly the same system that flows people back to the war. And part of it's culture. If you're a commander in the war and you wanted to send somebody back to treatment, it would look kind of bad if you sent them out of theater and then they came back really quickly. So like part of that would be, a culture change to have to achieve. But when we do treat people in theater, and these are small studies that we did, we did this in 2005, looking at basically the period, back basically to the period I was there and a little bit earlier. The first people in theater doing that would have been Alan Hayes, who works for the VA, I believe still down in San Antonio, that did some chronic pain in that environment in OIF-1. And then Ron White, who's out working as a contractor for the Air Force now on the West Coast, had published a series basically saying, hey, these patients that we selected, this case series, did well. They tended to stay in theater, and they did a lot better than the very low single-digit percentage of people returning to duty because they didn't get treatment and also for these other reasons. So the bottom line on that chronic issue is the jury's still out. So what's the takeaway I want you to get from this first period? One is that multimodal analgesia, including regional anesthesia, is well suited to modern combat injuries, that can help those patients do better. We know that treating them early can affect their outcome. So being on top of that and adding things, and again, I'm not going to tell you everything we do because I brought somebody to help me with that. So we're going to talk a little bit more about that later. But the MSH uses regional anesthesia and acute pain services. Patients have come to expect it. So as we interact with the civilian system, it's important that the people taking care of them know what our patients usually get and what they would expect to be able to provide those services if in fact they do. And the bottom line is chronic pain treatments may be appropriate for deploying soldiers. That hasn't been well studied yet. We kind of talked about that at the time. You can imagine after the surge and later in that period, people weren't excited about building up new capabilities. Rather, they were trying to decrease the footprint of the force in the war. And that's something that's still out there to be looked at. So the second period I'm going to talk a little bit now is 2000 to 2013, 2007, sorry, to 2013. And again, this is the period when we started to realize there was a pain problem and also a prescription opioid problem, and kind of tied it to that. All military services responded to instances of inadequate pain control and treatment complications, particularly opioids during that period. I'm going to talk more about the Army experience because I lived that one more, but if you were talking with Ivan Lesnick or Steve Hamling from the Navy side, they would have a similar story with a little bit more of a Navy bent. But these are efforts that were sanctioned from above, and then every service had some version of what they were doing to try to improve pain and to make it safer. So this really came about to address uniformity care. Most of what we needed to have in this chronic pain realm existed, but it wasn't the same across the services. So that was, it wasn't the same across the services, and it wasn't the same across any service. That was surprising to some people because you think about the military being uniform, but in medicine that's not necessarily always true for military medical facilities. And the hope was to identify those practices and then to spread them to other places that didn't have them, and also, frankly, identify any practices that were counterproductive and stamp those out as well. And it resulted in a lot of discussion and cooperation between the military and VA pain specialists, but also with civilian specialists, and particularly integrative sites is one thing that we looked at, in addition to talking more with people who do what I do as a pain subspecialist. Most of you probably have some amount of practice of doing therapeutic interventional injections, implanting implantable pain devices, and that's all the spectrum of what I do in my clinical practice in the military. And those things were things we looked at there. This is what, and I'm not going to read this to you, but if you went, and you should give credit to the Army Surgeon General at the time, basically this was sort of the mandate of what we were trying to do, and to a large extent I think a lot of this was successful, so I think that made a good impact. So this is how they got the information: site visits, data pools from our own healthcare record. Actually, the old healthcare record from the 80s is the one sometimes it's easy to get data from. Interviews with people at various sites, and reviews of medical literature. This went on for about a year, so this was a pretty in-depth thing where we went out to these sites. This is kind of what it looks like. I'm not trying to get you to memorize any of these sites. I want you to get the idea that these are a lot of sites across the country and beyond. This includes sites that are in the VA, it includes sites from all services of the military, and it includes sites from civilian pain organizations. University of Washington was one thing they looked at what I'll come to, a patient assessment screening tool and outcome registry, or PASTOR is something that grew up out of that that's still beginning to evolve. The idea of Defense and Veterans pain rating scale that you'll see a little bit later also grew up in this idea of tying function more to what we're asking about, not just a numeric pain scale. So the other thing is working with the VA, and even to this day, DHA has adopted a model of this. It's kind of a circle now, but it's still called step care. And this was the idea of, hey, most pain care happens at the level of primary care. And in that period, that was certainly true for prescriptions. This is an older, probably version even of the VA's picture, but I think theirs still looks more like this. So the idea was empowering primary care providers with education, but also resources, having a second step where you had a person with additional capabilities that could either see that patient or do very targeted education, where they used something called ECHO that grew up out of the University of New Mexico with chronic liver disease, where was really designed to go over long distances in a rural area and be able to provide expertise, where you basically put in what you were looking to be educated on, as in, I have a patient with these problems and this comorbidities, and I want to get an idea of how I might treat them. So it was still in the realm of education, but it was very targeted, detailing exactly what you needed to know at that point as a primary care provider. And then finally, we're the tertiary center. And this is really important. These interdisciplinary pain centers were a result of this task force that led to a campaign plan. And this is a leadership thing where when you actually have what typically would have been a chronic pain clinic or even an acute pain service being a subset of an anesthesiology department. If you've worked in hospitals, you understand what I'm saying. you moved up in many places to being a department level. So you basically made 2 jumps, and that gives you a seat at the table. You can imagine what that can do for budgets and resources and those sort of things. So that's, to me, is one of the main reasons this stuff was successful, and the interdisciplinary pain centers were able to really not just talk the talk, but actually provide multimodal interdisciplinary care. So again, I'm not going to read these to you, but there were obviously there are 109 recommendations in 4 areas. But I think the biggest things to take home for this was about providing tools and infrastructure, and I think that goes back to what I was just saying. Regional commands knew that this was a priority then. The leadership of the military had set aside funds to actually create these job positions, to have an integrated team. What does that mean? They had pain physicians, but they also had integrative physicians. They had physical therapy capabilities. A lot of these things were in-house under the same leadership, which made it easier. In other settings, they were in the same facility and available, but not necessarily under the same department. And those sort of relationships are important in making a multimodal interdisciplinary approach effective, because you have to have that buy-in from a high level. If you have to get some of your resources from another department, you have to convince them that they in fact need to give you those resources instead of whatever else they were already doing with them. Big focus on the family. It's important a lot for taking care of patients, and to a certain extent, some of the problems we had that were bad that got into the media, when you look at doing outpatient medicine for a facility that originally been designed to do it inpatient. If you look at Walter Reed Gate or whatever you want to call it, when there was a problem with outpatients that were pretty severely injured being housed there locally, that kind of communication with the family to really understand, what kind of support does a particular patient need, what kind of structure does it take to keep them in the right place at the right time and get their care in a coordinated fashion, is an important piece. So it's important to focus on the patient, but frankly, it's important to focus on their family as well. So what is my takeaway? I've already shared with it, but if I was going to emphasize one thing, if there are parts of this that you want to take and try to implement in the civilian organizations you work in, it would still be that you have to change the wire diagram. When you look at DB-CIPM, Defense and Veterans Center for Integrated Pain Management, that evolved from a regional care organization. But because of this buy-in from senior leadership, it was then able to affect policy, affect how we do things, how we resource things. It helped answer over time important questions that led to things like, fentanyl lollipops on the battlefield for wounded special operations people, and gave, related input. If it's good to have this for special operators, is it good to have it for every man, woman, and child? And that's when it's good to have the expertise say, no, maybe that's not the best idea. So those are kind of the pieces that come into that. It borrowed a lot from the VA and step care and scan echo to empower primary care. And I think one of the things over time we learned from that yeah, it's good for what it was originally designed for covering distances when we're trying to support another provider in the war, or we're trying to support another provider at a remote post. But it's also good sometimes in the city. If any of you live by a major city like Washington, D.C., like Belvoir is the other part of, I worked at Walter Reed, so the other part of our health system up there would have been Belvoir. That's not geographically that far from Walter Reed. It's basically you're driving all day if you go there and back. So a lot of times these leverage these technology capabilities can really add some efficiency that mimics you. In many ways, I don't know that we frequently come close to the efficiency of the civilian system, and I think that's why it's important for us to have these relationships, to understand how you develop the efficiency that many of you do in your practices. In many ways, I've said this, the Army is at its heart an organization about effectiveness, not efficiency. Efficiency is important, but you have to be effective even if you're inefficient. If you're not, you end up speaking another language. So it's a little bit different focus, and it's good to get perspective from outside about how people are able to be efficient, because the things you assume they're doing isn't always what they're doing. Yet there were still problems. So this second period ends. There's still a lot of things that are problematic in 2010. Many patients, civilian and military, were still treated pretty liberally with opioids at that period. There were patients that may have been able to benefit from a multimodal approach with fewer or no opioids that just weren't getting access to that. That wasn't the same priority as it is today at that time period. The problems that to a certain extent still exist are that outcomes are hard to measure with mixed results. So when you looked at different treatments, it wasn't Many of you realize this perhaps better than I do telling you. Like he said, with my 2 weeks of private practice, I may be more enlightened to it than I was in the past. But the idea that some of the things we do that require multiple providers, multiple treatments, multimodal analgesia are not scalable to a large population as large as you may be treating. So proper patient selection for applying resource-intensive treatments is going to be very important in the civilian sector. Frankly, it's going to be very important in our system. If we try to do everything for everybody, a lot of the things I'm talking about were done primarily for active duty people that were being returned to duty, to people that had been gravely injured in the war and had that focus. But certainly not every patient in every place was getting exactly the same level of resources to them. And perhaps that makes sense because it could exacerbate disparities in health care or create untenable costs of the care. So when we talk about the third period, this is my other demotivator slide, there's probably plenty of people to blame, but not necessarily much productive to come out of it with how we came to have an opioid crisis that evolved into a bigger problem. This is a slide from the CDC, and you can see there around 2012 to 2013 where we see a big rise in illegal opioids, particularly synthetics, from sources outside the country. So this is sort of the end of the prescription problem driving opioid complications and the start of illegal sources being the big morbidity changer. And this is important because it changed the focus in the military, I think, and I think in a good way. So before, this was seen as a bad thing for patients. This was seen as a bad thing for our veterans who had been wounded, but it wasn't necessarily seen as a huge impetus to combat power. Now with the opioid epidemic, just like civilians, there are people affected by this that are not patients from abuse and everything. This then becomes a combat power problem, that you have people that are well-trained that, if this isn't being prevented, if this isn't being treated after it occurs, you actually lose your resources that can fight the war. So there is a big focus on how this not only affects patients, but how it affects military readiness. Are you able to fight? Is this something that can impede your ability to do your job? There was a lot of focus on decreasing or eliminating opioids with this realization, and I would say it was on par with the focus on pain. See, in that second period, the focus was really on pain. It was like people that were not getting adequate pain, and how can we do that safely? But the focus on opioids became so strong. And why is that important to you? Because we're working together and sending representatives to create the guidelines that affect how we work. We are frequently benchmarked to the civilian side, and the civilian side is frequently benchmarked to us. It's often the case that the military is in a better position to send somebody to a CDC guideline panel. Like I had a person on my team from the National Capital Region Pain Initiative that I directed that went and was a representative that helped create the guidelines that have created some controversy. I've been involved in the HHS panel that's probably trying to rebalance that to a certain extent with the Vanilla Singh led and looking at trying to say how can we still maintain the use of opioids for patients that are appropriately used in an appropriate setting? How can we make that safer when the complete elimination of opioids? How can we affect sort of a fairness, if you will, in consideration of evidence-based treatments? In other words, why would you take away an interventional treatment with an equal evidence and safety base to replace it with an emerging integrative treatment that may not have any difference in terms of the data supporting it? And those sort of things are things that I expect in your setting you deal with some frequency. So, and that kind of gets to, what can we do? Like we do things and we try to make things better, but it doesn't always end well. So like, we look at some of the things during this period that I think are cautionary, and I think there are things that support when we speak our message well about why interventional care remains important, why, a patient with a spinal cord stimulator may have their life changed positively for many, many years, and telling that story is something we need to do well, that when you really look at the numbers, the morbidity for opioids is far and away higher than the morbidity for almost all of the treatments we provide combined outside of that. And that's important that we are able to have that message. And where is that being told? So what are the unintended consequences? Well, when they started trying to do this, the military ran into, I think it was on the order of a couple $1 billion problem with compounded pain creams. Like some of those people that did that got the appropriate reward. But there were problems there on the side of obviously the people doing it, but then the need to do better business, and on both sides being able to tie the people that realize what money is flowing to try to provide health care and look at the evidence base. There was probably a time earlier that you could have said, hey, this doesn't line up. This amount of money and this amount of evidence don't really go together, and those sort of things are always at risk to happen again. And I think it's important that we understand that, but also tell that message to the leaders on the civilian and military side as we go, to let them know, so that becomes a cautionary tale and not just a point in history. And I think one of the most important things is that we maintain coverage for existing interventional treatments, despite their challenge, despite the safety and evidence base being equivalent or frankly in many cases better than some of the emerging treatments that are being considered. So what happens next? I think the HHS pain management best practices interagency gives us some insight to that, and I'm out of time, so I'll go quickly. But when you ask what research should be prioritized, I think we need a combination. Yeah, I think we still need RCTs, but I think we need outcome measurements. We need to know when we do something, does it actually work? How's it working? And I think things like PASTOR can help with that. I think the DBPRS can help with that, just how you measure pain. Are we talking about in terms of function or only in numbers? And then I think it's somewhat reassuring. This is Vanilla Singh talking, but at least clinically while I'm in practice, I usually talk to patients about 5 things that we can do that line up pretty close to this if you read that slide. So I usually talk to them about medications that we can manage for them, both opioid and non-opioid. I talk to them about interventional treatments, both diagnostic and therapeutic, up to and including interventional pain system. I get a little bit off this slide because I talk about surgical therapies and how that plays in, and I think working closely with our surgical colleagues for people that end up needing surgery remains important. And then 4th, various allied health professionals with behavioral health and physical therapy. And then finally, integrative treatments that we've been fortunate to be able to offer in the military, even in settings where it wouldn't be covered either by our insurance, TRICARE, or out in a lot of the civilian programs. And this isn't exactly that, but it's pretty close, and it gives me confidence because I've done this for quite a number of years, and I believe that kind of focus on the realm of treatments available gives people good care.